All right, I'm starting the timer if you're ready.
Okay.
Started the timer, and here is your question. Right, if you have read and understood, kindly tell me. Just a second. Can you please identify the bones? In A, what is this 2?
Okay. This is slide A. This is dorsal surface of the left scapula, and B. This is anterior surface of the left scapula.
Okay, can you identify structure 2, what that is?
Yeah. Number 2. This is acromion.
Okay, what is this 10?
This is a spine on the posterior surface of the scapula.
Okay, 15 please. 15.
What's mom?
15?
15. This is
Yes.
supraspinatus fossa.
Fossa. What attaches
Supraspinatus
here?
fossa.
Yes, what attaches here?
Yeah, this attached spinatus muscle responsible for stability of the shoulder joint.
Okay, what is 5?
This is infraspinous fossa attached to the infraspinatus fossa.
Can you please tell me the
Infraspinatus
yes?
muscle.
Can you please tell me the origin insertion of infraspinatus muscle?
Yes, the infraspinatus fossa origin
Muscle.
from the
Yes.
infraspinatus fossa insertion into the greater tuberosity, and the supraspinatus from the supraspinatus fossa and the insertion to the greater tuberosity.
What is the
And
nerve
the nerve
supply?
supply the same from the
Yes. Yes.
yeah, the nerve supply the same from the suprascapular nerve, and the action of the supraspinatus abduction and external rotation and the stability of the shoulder joint, and the infraspinatus responsible for the external rotation and the stability of the shoulder joint.
Good. Okay, in picture B, can you please tell me what is 11?
This is subscapular fossa and attached to the subscapularis muscle.
Okay. What is the nerve supply of subscapular muscle?
Yeah, this is nerve supply upper and lower subscapular nerve from C5 and C6 from the posterior cord of brachial plexus.
Okay, can you please tell me how the shoulder joint is formed?
The shoulder joint performed by the
Here's the picture here.
head of
Yes.
the humerus articulate with the glenoid labrum and the lateral end of the clavicle.
Okay. Can you please tell me what do you understand by the rotator cuff muscles?
Yeah, the muscle responsible
Yes.
for the stability of the shoulder joint as subscapular from subscapular subscapularis origin from the subscapular fossa and insertion to the lesser tuberosity and the nerve supply upper and lower subscapular nerve and the action internal rotation of the arm and the providing anterior stability, and supraspinatus and infraspinatus from the supraspinatus fossa and infraspinatus fossa insertion the same greater tuberosity and nerve supply the same the suprascapular nerve and the action the supraspinatus abduction and the external rotation of the arm and providing stability, and the infraspinatus external rotation and providing stability, and last one the teres minor from the dorsal of the dorsolateral surface of the scapula, and the insertion into the greater tuberosity, and the nerve supply, axillary nerve from the posterior cord of brachial plexus C5 and C6, and the action, external rotation, and providing stability.
Okay, where the shoulder joint is weak.
The shoulder joint
yes.
is weak at the lower part of the and the inferior aspect of the glenohumeral due to presence of the quadrangular space and the shallow glenoid cavity and lax capsule with the few ligament because of the capsule not covered the shoulder joint inferiorly.
Okay, can you name few muscles and few ligaments which are attached to coracoid process, please?
As ligament, coracoclavicular ligament, and coracoacromial and coracohumeral, and muscles insertion for the pectoralis minor muscle and coracobrachialis and short head of the biceps as origin.
Good. Can you please tell me what are the boundaries of the triangular space below the shoulder joint?
Yes, the triangular space. This is triangular boundaries between upper border teres minor and the lower border teres major, and the medially long head of the and long head of the and laterally long of the triceps, and the content circumflex scapular artery.
Okay, so can you please tell me what are the things which pass through the quadrangular space?
The quadrangular space passing to one nerve and two artery, as one nerve, axillary nerve, and two artery, posterior circumflex humeral artery, and the humeral artery from the third part of the axillary artery.
Can you please identify from number 1 to 10? In picture D, please.
Yes, this is arthrogram MRI of the shoulder.
Yes.
Identify number 1, this is acromion, and 4 clavicle, and 5 deltoid, and 8 head of the humerus, and 9 supraspinatus muscle, and 10 supraspinatus tendon, and 6 glenoid labrum, and 7 glenoid cavity, and 3 axillary recess, and 2 axillary nerve, and the posterior circumflex humeral artery.
Can you please tell me about the axillary nerve? What are the muscles which are supplied by the axillary nerve, and what kind of injury do you expect if axillary nerve is injured?
The axillary nerve arises from the posterior cord of the brachial plexus from the C5 and C6, supply to deltoid muscle and teres minor, and sensory supply to the badge area at the lower half of the deltoid. If injury of the axillary nerve led to loss of the abduction of the shoulder over 50 degrees and loss of the sensation over the skin on the lower half of the deltoid as badge area.
Can you name the muscles inserted in the bicipital groove?
Floor, latissimus dorsi, and the medial lip, teres major, and lateral lip, pectoralis major muscle.
And the tendon of long head of biceps, it lies?
And tendon of long of biceps in the groove.
What are the movements which are possible at the shoulder joint?
Yes, the movement of the shoulder joint, flexion, extension, abduction, adduction, and medial rotation and lateral rotation. As flexion performed by the pectoralis major muscle and the anterior fiber of deltoid and biceps and the coracobrachialis, and the extension like posterior fiber of deltoid and the latissimus dorsi and teres major and triceps, and the abduction from the 0 to 15 as supraspinatus, over 15 deltoid, and over 19 as trapezius and the serratus, and the adduction like pectoralis major and latissimus dorsi and triceps and the teres major, and the medial rotation like the muscles latissimus dorsi, pectoralis major, teres major, and posterior and the anterior fiber of the deltoid, and lateral rotation like posterior fiber of deltoid.
Okay, please, sorry, I have to interrupt you. Can you please tell me what else assists when you're doing overhead raising of the arm with serratus anterior and trapezius? What else? What else assists the upward rotation Of the arm? Or
Yes,
the...
upward rotation of the scapula with
Yes.
lateral rotation of the humerus.
Very good. Very good. Bell has gone. Yes. Okay. Can you please, before the end, tell me about the axillary artery? From where
Yes,
it
the
begins,
axillary.
how it divides? Yes.
Yes, axillary artery arise as a continuation from the subclavian artery at the upper border of the first strip and the end at the lower border of the teres major, and divided by the pectoralis minor muscle into three parts. As the first part give superior thoracic artery medial to the pectoralis muscle, and the second part give thoracoacromial and lateral thoracic artery. Thoracoacromial give deltoid and the pectoralis and the clavicular and acromial branches, and the lateral thoracic artery. And the third part give three branches. As the largest branch, subscapular artery, give thoracodorsal and circumflex scapular artery enter into the triangular space and the anterior and posterior humeral circumflexia surrounding the surgical neck of the humerus.
Good. Thank you so much. Bell has gone. Good. Okay. Started your timer and your time begins now, please. Here is your question. Yes. If you have read and understood, kindly begin your examination.
Okay. I entered the room and then I washed my hands.
Yes.
I introduced myself and
Yes.
confirmed the name and age of the patient.
Yes.
And then I take the permission from the patient to examine her back and legs, which will include
Yes.
the looking, feeling, and moving the backs and legs.
Yes.
And after that, I'll ask the patient to take off the gown and remain in the shorts. I'll help for the same.
Yes.
After that, I'll ask her to, if there is any pain.
Sorry, how would be the position of the patient while when you begin your examination, please?
At present, I'll ask the patient to remain standing.
Yes.
And then I'll ask that if she has any pain right now and need any painkiller, then I'll see that if a patient is using any walking aid like crutches or cane. Yes. Or anything present, or if he uses to stand, then I'll ask that to walk a few steps in front and then turn around, and then I'll also walk with the patient so that she could not fall. I'll prevent that. And after that, I'll ask the patient to walk on the heel first and then yes. on the toes, on yes. her toes. After that,
how would your position be when the patient is walking on the tiptoes?
I'll take yes. One of my hand in the front and yes. one behind the patient so yes. that she could not fall. I'll walk with her.
And you'll reassure the patient first.
I'll reassure the patient that she would not fall because I'm preventing her from
Good.
falling. I'm with
yes.
her.
Yes.
And then I'll also look the patient. I'll see the patient's head and shoulder from the front.
Yes.
Then I'll see her from the side for any presence of for the normal cervical lordosis and lumbar lordosis and also the thoracic kyphosis. Yes. After that, I'll examine the patient from the back. First, I'll look for any swelling, any scar or deformity like scoliosis or muscle wasting, or if there is any abnormal hair growth. After that, I'll ask, start.
What else is most important on visualization or on inspection?
Especially scoliosis, muscle wasting, and
yes.
Any scars.
Scars, yes.
Yes.
Good. Yes, and, please go ahead.
Then I'll ask the patient that I'm going to feel the spine And I'll start by feeling the temperature with the dorsum of my hand
Yes.
and moving from below upwards. After
Yes.
that, I'll start for feeling the tenderness from the cervical region going to the lumbar region, and I'll palpate for the spinous processes, then paraspinal muscles, and also the bilateral sacroiliac joints. After that, I'll do the modified sober test, for which I'll ask the patient that I'm going to put some marks on the back of and if she is okay with that, then I'll put one mark 5 centimeter below and another 10 centimeter above the posterior superior iliac spine in the midline.
Yes.
After that, I'll ask the patient to lean forward and try to touch her toes with
Yes.
fingers. And at that point, I'll measure the distance between the 2 points. If it increases more than 20 centimeter or it is less than 20 centimeter. If it is less than 20 centimeter, it suggests ankylosing spondylitis. Then I'll ask the patient to imitate the movement. What am I doing? I'll explain how to do the flexion, extension, then lateral flexion, and also the rotation. By doing myself, I'll explain her to imitate me.
Yes.
And then I'll ask the patient to lie down on the bed, and I'll ask if she has any pain in the hip at the moment. After that, I'll raise the patient's leg passively, keeping the knee straight, and look for any tenderness. See the patient's face for seeing any tenderness, and then I'll. At the moment when the pain increases, I'll stop that, and then I'll do the dorsiflexion at the ankle joint to see the pain increases or not, to see the rescue sign. And after that, I'll bend the knee and then see if the pain decreases or not. I'll do the same examination on the contralateral side also.
Yes.
After that, I'll start the neurological examination. First, I'll test the sensation. First, I'll touch the patient's arm or chest with the cotton weight and ask if she can feel it. And I'll ask that if she feel like that, and then she will say yes. I'll ask the patient to close her eyes.
Yes.
Then I'll start touching, starting from the lateral malleolus, dorsum of the foot, over the medial malleolus above, then anteriorly at the lower thigh, mid thigh, and upper thigh. I'll do similarly with the pinprick sensation and also on the opposite side of the legs. And for the motor examination, I'll first test the power of the legs. I'll ask the patient to first I'll put my hand below the knee and ask the patient to stop me from lifting the legs.
Yes.
Lifting her leg off the bed, and this will test the hip extension.
Okay.
Okay, I'll thank the patient. I'll inform the patient that I'll discuss the case with my consultant and inform about the further course to her.
All
then,
right. So what are your differential diagnosis?
Okay. Depending on the to complete my examination,
very good.
I'll do the complete neurological examination of both lower limb as well as the cervical spine examination, also neurological examination of the upper limb.
Yes.
Okay. So today I have examined this lady who presented with low back pain, and so I did not find find that she could not perform the heel walking. She could not.
Okay.
She is not using any walking aid, but she could not do the proper heel walking, and there is no deformity in the back.
Yes.
And there is no swelling or a scar mark. Temperature I felt is normal. There is some tenderness over the lower back, and there is a movement of the spine is painful.
Yes.
Modified sober test is negative, but when I do the straight leg raise, it is positive with positive rescue sign.
Yes.
And as I did not do the neurological examination, but I think there will be some deficiency of the neurological deficit will be present there.
Okay. So what are your differentials that you are going to consider?
In this, I'll first consider the prolapse intervertebral disc.
Good. Okay.
Mainly lumbar area, most probably L3, L4 or
L5.
area.
Yeah.
L4, L5 area.
Yes.
And I'll also consider the spinal canal stenosis
Yes.
or diabetic peripheral neuropathy, or
Yes.
there may be vitamin B12 deficiency, or even the carcinoma causing the carcinoma primary
Metastasis.
or
Okay.
primary or secondary. Yes.
All right. Can you please quickly tell me the management of this patient?
I'll start with the imaging with X-ray lumbosacral spine AP and lateral view, followed
Yes.
by the MRI of the lumbosacral spine. Also do the routine investigation and investigation to rule out the diabetes and other metabolic disease. And then I'll discuss the case with the
Yes.
consultant. Then
And
I'll offer the
MDT.
patient conservative treatment.
First,
MDT. After
yes.
MDT, I'll offer the patient conservative treatment with lifestyle modification and physiotherapy.
Yes.
And then medical treatment with analgesic, muscle relaxants, and vitamin B12 supplementation.
Yes.
If
that
she
fails,
could not be,
yes.
if that fails, then I'll ask the patient to go for surgical treatment, which will include the discectomy or laminectomy, which can be either open or endoscopically or minimally approachable, minimal invasive approach of laminectomy.
Good. Okay, thank you so much.
Thank you, ma'am.
Second, yes. So 1 minute extra I gave you, but
actually,
yes. We'll begin with you. So how was it doing it?
Actually,
yes, please.
This is a very long clinical examination.
Exactly. Yes.
Yeah, doing the neurological examination itself is very long. Yes.
I agree. But if you have done enough practice, you can manage it in a given time.
Okay, I'll try again.
Yeah, we'll practice again and again. So you tell me how was it? Like, yes, you yourself knew that you couldn't complete. So when I asked you to present your case, you started with, I would have completed my examination with that. So that was as good as being done.
Yeah, I thanked the patient, and then I said that I'll do this.
So, yes. And you, at the same time, when you were doing, you were telling that you'll perform the same examination on the other side as well. So there again, you got the marks. Okay. So yes. What more? If you would have had enough time, what more you could have done?
I reached up to the motor examination. I was doing the power of the hip. Then I would have done the knee motor examination, then ankle, dorsiflexion, plantar flexion. After that, I would have done the coordination as well as tone and reflexes, knee and ankle reflexes. I also have done the clonus. And the last but not the least, I think I will also should have done the femoral stress test, nervous stress test in this case.
Yes.
Yeah.
Very good. Okay. Anyone else want to give feedback? Because everyone had the task to read the same thing. So you would have to give feedback to let me know that you are also studying, you're also following the schedule. Anyone?
Today I also read the foot drop examination. I found that the only difference between this and the spinal lower limb examination is that in the spine we have to do the spine examination as well, but in
not in
foot
the
drop
foot
only.
Drop. Yes.
Lower limb. So that one is a little shorter than this one. Just I think.
Yes.
Yeah. 2/3.
Yes.
But almost everything is same, except I think this femoral nerve stretching is we do not do.
No.
Yeah, and straight leg raising we do not do. Other examination we do the same, almost same.
Almost. Yeah. Anyone else want to comment or say anything?